So we start the recording. The first case will be a case, all the both case will be a cases on station 5. So Dr. Komal, here your case. 34 years old female, presented with difficulty in walking. 1 minute and we are going to start.
Okay.
Okay?
Okay.
Okay, doctor, let's start.
Okay.
Okay, the scenario again, the scenario again for the people who just joined. It is a 32 years old female presented with a difficulty in walking. Okay, so station 5 case. Okay, let's start.
Okay. Hello, good afternoon.
Good afternoon.
My name is Dr. Zahid. I'm one of the doctors in the clinic. Are you Miss Sarah, 32 years of age?
Yes, doctor.
Okay, so Miss Sarah, we're here to discuss about your health condition. Can you tell me in detail about your complaint?
Well, doctor, over the last 4 days, I start to feel like I can't walk because I have a pain in my leg, doctor. It really preventing me from doing my just simple daily activity. I can't walk. I can't do anything, doctor, without feeling comfort. Without I can't do anything, doctor, throughout the day without feeling this pain.
Okay, I'm sorry to hear about that. Can you tell me, is this pain present in both the legs?
No, doctor, it is in my right leg.
And besides that, do you have pain in any other part of the body?
No, doctor, mainly in my right leg.
And in which part of your right leg?
Actually, doctor, I feel like it is just below my knee, doctor.
Is it present in the joint or in the whole of the leg?
Well, it is, I don't know, doctor, but I feel it is more below the knee.
Okay, and 4 days back it started suddenly?
Yeah, it started suddenly, doctor.
Any history of fall or trauma before that?
No, doctor.
And is this pain present throughout the day and night or at any specific time?
Yeah, doctor, all over the day. I don't feel it happen at a specific time.
And what type of pain is it? Is it a sharp pain or throbbing pain?
Yeah, it is sharp pain, doctor. And I feel also like there is a swelling also with this pain, doctor. I feel like my right leg is getting more bigger than my left leg.
Along with skin?
Sorry, doctor, I couldn't hear you.
Any changes in overlying skin color?
Well, I'm not quite sure, doctor.
Okay, and is this pain made worse by anything like walking?
Well, yeah, walking make it worse, but even while I'm sitting down, I still feel this pain, doctor.
Does this pain go anywhere, like in your back?
No, doctor, no.
Any problem with control over waterworks or bowel works?
No, doctor.
Any numbness or tingling or weakness in your leg?
No, doctor.
Okay, and do you have any raised body temperature?
No, doctor.
Any lumps and bumps?
No.
Any weight changes?
No, doctor.
Okay, and can you tell me, do you have any history of clots in your legs or lungs ever?
No, doctor.
Any complaint of sores anywhere in your mouth or any other part of the body, like private areas?
Yeah, doctor. I have this mouth sore. I think I developed it about. I used to have. I used to have this mouth sore. I think 8 months ago, but it resolved alone, doctor.
Was it painful?
Yeah, it was painful, doctor.
Okay, and do you have any rash anywhere?
No, doctor.
Any history of hair loss?
No, doctor.
Okay, I'm going to ask you some personal questions. Are you in a relationship?
No, doctor.
Any history of how are your periods?
I feel my period. It's okay, doctor.
I'm sorry, it's a routine question. Please don't feel awkward. Any history of pregnancy losses or any children, any past deliveries, anything like that?
No, doctor.
Okay. Do you have any chest pain or racing of the heart?
No, doctor.
Okay. Any past history of note?
Well, aside from this mouth sore, I felt also like maybe 1 year ago or 2 years ago, I also had a sore in my private region, doctor. I used to follow with my woman doctor, but I think it resolved alone. She gave me some topical medicine, but it didn't help me. It resolved alone, doctor.
And they were painful as well?
Yeah, it was painful.
Okay. And do you take any medications on regular basis?
No, doctor.
Any oral contraceptive pills?
No, doctor.
Okay. And any family history of similar complaints?
I'm not quite sure, doctor.
Right. Any recent travel?
No, doctor.
Okay. So can I ask you, what do you do for a living?
2 minutes remain. I'm accountant, doctor.
And do you smoke?
No, doctor.
Or do you drink alcohol?
No, I don't drink alcohol.
Okay. I'm just going to check the patient's hands for any joint deformities. Anything abnormal in the hands?
It's okay, normal.
Okay. I'm going to check the pulse and ask for blood pressure.
Okay, pulse is regular, average in volume, equal on both sides, blood pressure is normal.
I'm going to check in the eyes for any in the mouth for any mouth sores.
Yeah, there is visible mouth sore.
And I'm going to check the legs for any overlying skin abnormality, and I'm going to check for warmth, the temperature, and tenderness.
Okay, it is there is some hotness over the right leg. There is some redness also over the right leg, and
And
it is painful when you press it. If you press it,
the pulses are fine.
pulses are fine.
And I'm going to check pinprick sensation.
Okay, your time is almost finished. Examiner question. Okay, what's your finding in this case? Physical finding in this case?
The patient has a history of mouth sores, and currently she's also having mouth sores which are painful, and history of painful sores in the private areas. Currently she's just having swelling in the right leg with the redness of the overlying skin, and it is tender to touch. The pulses and sensations are normal.
Okay, so what's your diagnosis and what's your differential for this case?
On top of the list, I would like to keep deep vein DVT, secondary to Behçet's disease.
Okay, what else? What's your...
And the differentials could be cellulitis of the right leg or lymphedema.
Okay, any other risk factor for DVT in this patient other than Behçet?
Along with, I don't think so.
Okay, how you are going to investigate this patient and how you are going to treat her?
For the investigations, I'm going to completely examine her, and then I'm going to do the complete blood count, the ESR CRP, and I'm going to do the autoimmune profile. The test for Behçet's disease is the pathergy test. And other than that, I'm going to do the ultrasound of the legs for Doppler ultrasound to look for DVT.
Okay, if it came negative, what are you going to do?
If the Doppler ultrasound is negative,
Yeah.
then
Any blood test you are going to consider? Okay, if it is positive, what if it is positive for DVT, how you are going to treat this patient?
if it's positive, then I'm going to admit the patient, and I'm going to start her on low molecular weight heparin IV, and for now, and then we can overlap it later on with oral anticoagulants. And I'm going to also offer her support in form of support at work and at home. And also for the underlying Behçet's disease, maybe I'll involve the joint doctor, the rheumatologist, and probably she will need lifelong
Okay,
anticoagulation.
your time is finished, doctor. Thank you so much. Okay, let's start the discussion from the beginning, the case from the start. What do you think you missed in the history? Okay, this is now aside from the case, just between me and you and your colleague. Now they are free to comment or give their
I
feedback
should
if
have
they want.
asked about any immobility, travel history, or
Yeah,
any surgeries.
yeah, this is very important. You forget to ask about the other risk factor for thrombophilia in this case. Okay, what else?
Dr. Allah, you gave me 7 minutes or 8 minutes?
I give you 7 minutes because we are not doing a clear examination or a real examination. Okay? We are just simulating, or you are just mentioning for me what do you want to examine, which part of the body, and I'm giving you the positive finding. So we practice on 7 minutes. Okay? Okay, in the history, what else you think you missed?
I asked about oral contraceptives as
Okay,
well.
good.
Other than that, I asked about any relationships as well.
Okay. Why you ask about relationship?
I wanted to rule out any sexually transmitted infections that would also cause sores.
Okay, how you can relate that to the DVT?
It could cause Reiter's syndrome.
Okay, but by the way, I don't have an answer to this question. I'm asking you if sexual transmitted disease can cause. Okay, you said it can cause sore, but
Like HIV can also cause increased risk of thrombosis.
okay, but will it cause an ulcer?
It can cause ulcers. There's
Okay.
infective.
Let's take it simple. Can you mention for me the risk for thrombophilia? Just quickly, what do you think the most important things I have to ask it to the patient so I can know if he has the risk factor for thrombophilia or not?
We
You
can
ask.
ask about PNH, any
Okay.
changes in urine color,
Okay.
and other than that, SLE I asked. I asked about hair loss and acne.
One of the important risk factor for thrombophilia, very important, very crucial at the exam. By the way, you asked me some
Cancers I
questions.
also.
You asked me some of the question related to what I'm looking to hear from you, but I need you to mention for me just one word. One of the main risk factor for the thrombophilia, very important, very crucial. You have to ask about it. What do you think it is?
Recent deliveries I also asked for any
Oh,
postpartum. Then I
okay.
also
What
ruled out
else?
malignancies.
Yeah, cancer. This is what I was
Yes,
looking
I
to hear
asked
from
about
you.
lumps and bumps.
Okay, lumps and bumps.
Babies.
That's great. That's great. Okay, in the examination, sorry, in the history, what else you think you forget? If this patient has a DVT, what we are looking for?
Contraceptive pills?
I should have asked about shortness of
Just
breath.
wait a
This
minute,
is not
Dr.
mentioned.
Said. We are welcome,
Pulmonary.
Dr. Said. Sorry, pulmonary.
Pulmonary embolism. I should have
Okay.
asked about shortness of breath, I think.
Okay, this is very important. You have to look for the red flag following the DVT that the patient may develop at any time pulmonary embolism. You have to ask about the shortness of breath. You have to ask about the chest pain. You have to ask about the awareness of heartbeat, the palpitation because of the sinus tachycardia. Okay?
I asked
Those,
about palpitations, but not shortness of breath.
okay, shortness of breath is the most important question in the patient with pulmonary embolism. It is even important, it is above the pulmonary, it should be asked before the chest pain, before the tachycardia, and even before the hemoptysis. Okay, the most common presenting symptom for the patient with pulmonary embolism is the shortness of the breath. The second question is the chest pain, then you can ask about the palpitation, then you can ask also about the hemoptysis, okay? So in the history, you forget to ask just about the other risk factor for thrombophilia. I think you asked me the most important question, but you have to just remember that the patient, if he had a recent history of admission, recent history of surgery, you asked me about the delivery, you asked me about if I was in relation, you asked me about the travel, which are a very important question. You did not miss them. In the history, you did not ask me just about the pulmonary embolism, if I have a risk factor of, if I have a symptoms of pulmonary embolism, which is very important question. You have to ask me those questions, okay?
Yes, this was
Okay,
a very long history. I lost all of the time on this.
okay, and by the way, when I'm telling you there is a pain in station 5, if the patient told you I have a pain, I have a swelling, if he told you I have a skin rash, always the first question you have to ask the patient is, show me where is exactly the site of the pain, show me exactly where is the signs of the, where is the swelling, where is the rash, okay? Because it's going to help you, it's going to save your time, it's going to, I think, save your life at the exam. Instead of just asking random question, you will know exactly what is the diagnosis from the first glance or first question, okay? Okay, doctor. So you should just ask me after I told you that I have a difficulty in walking. You should just ask me, can you please show me where is the site of the pain? If you notice there is a swelling, you should think about DVT and go with the history of the DVT. Okay?
Okay.
Okay. The good thing you asked me about the trauma to exclude other differential like a tear or any muscle strain. You asked me about the fever to exclude the cellulitis, which are also an important differential for this patient. If the patient has a rheumatological disease, it could be also rupture Baker cyst. You ask me exactly where it is swelling, which is very important question. And you have to ask me also if I have previous any skin wound or any trauma. Or, yeah, because we want to exclude the lymphangitis and lymph edema. Okay. Aside from that, your history was great. In the examination, what do you think you missed in the examination? Very important thing.
I should have listened to the test or for allowed me to.
Okay, before that, even something more important than that.
Measurement?
Yeah, the measurement. You forget the measurement. Okay, at the exam, you may notice that there is a tape somewhere around.
If it is visible to be large, still we should.
You have to show it. You have to demonstrate to the examiner that what you are doing. Okay? Usually the circumference supposed to be more than 3, discrepancy of more than 3 centimeters, suggestive of the diagnosis of DVT. This is very important. Okay, you may forget it here, but at the exam, please don't forget it. You may see at the exam, you may notice that there is a tape somewhere around the patient. It will open your mind, or it will direct you toward using the tape. Okay?
Okay.
Okay, don't forget the measurement. This is very important. And the pulse is very important because of tachycardia associated with the patient of pulmonary embolism if it was complicated.
Tachypnea, doctor, and cyanosis.
Tachypnea and cyanosis, okay. Tachypnea is very important also. Respiratory rate, you did not ask about it. Cyanosis, to some extent, yeah, but tachypnea is very important. You have to ask me about the respiratory rate, or you have to count the respiratory rate, or you have to ask the examiner, can I see the vital sign or the vital sign chart, just to see if the patient on shortness of breath and tachypnea, which can give you a clue toward the diagnosis of pulmonary embolism. Okay?
Okay.
So you exclude the trauma for the strain or tear. You exclude the Baker cyst, the cellulitis, the lymphangiitis. Those are the important question in the or important differential for the DVT. Okay,
Past history of similar condition and miscarriage.
Sorry, Dr. Hani.
Past history of similar condition and miscarriage.
She asked me about if I have a history before of clot, and she asked me about family history of similar condition. Okay, I am going to mention later on what are the risk factors for thrombophilia, but just let me finish the discussion with Dr. Komal, then we are going to repeat the case again and again, okay, to cover the missing point or to fill the gaps that we skipped them during the discussion with Dr. Komal. Okay, Doctor.
Excuse me, Dr. Ala. Excuse me, Dr. Ala. هو بين swelling in the knee joint. Why BE first? يعني DVT first. يعني ما it is not in the calf.
I didn't tell her in the knee. I told her below the knee.
Below the knee.
Yeah, below the knee.
Okay, sorry.
Okay. Okay, how we are going to investigate this patient, Dr. Komal?
Yeah, I said complete blood count, ESR, CRP, and autoimmune profile. We can also do the clotting profile to rule out any clotting defects. And
clotting
I think the
okay.
The diagnostic test is pathergy test.
And before you, better than saying the clotting factor, what do you, or I want to say, check the coagulation profile. You can say to the examiner the INR. Okay?
Okay.
Okay. What else?
Autoimmune profile to rule out any other coexisting abnormalities, like SLE to rule out SLE.
Okay, SLE SLE or mainly antiphospholipid syndrome. Antiphospholipid syndrome, if I was thinking about antiphospholipid syndrome, I'm going to ask for beta-2 glycoprotein and anticardiolipine antibody. Okay, if the history was suggestive for antiphospholipid syndrome, but in this case it's unlikely to be antiphospholipid syndrome. Okay, the most important test for this patient is
the Doppler ultrasound.
Doppler ultrasound. Please be sure to, especially if you don't have a time, if you thought that the discussion with the examiner is taking a long time, or it is exceeding the expected discussion time, always focus on the important thing, because Doppler have to be requested for the patient with suspected DVT within 4 hours. Okay, and I think the examiner, if you did not mention for him the Doppler, whatever else you are going to mention, all the previous investigation, CBC, autoimmune profile, coagulation profile, he will not give you any mark for that. Okay, so Doppler, it's very important to mention it, and don't forget it. If it came negative, what we are going to do for this patient? I ask you this question.
I'm not sure. Yes,
we have to check for D-dimer. Okay?
Okay.
Okay, we have to look for the D-dimer.
But then, Dr. Ella, if the ultrasound is negative, then that means that she does not have DVT. Then why do D-dimer?
Okay, there is a clear guideline from NICE. It was updated in 2020. This is a recent guideline. It will give you a clear, stepwise approach toward the patient with the DVT. You have to, in the beginning, to use the Wills score. Wills score, it's a score for, it will give you, it's a score we use this score to predict whether the patient has a DVT or not. If the score was more than 2, this is high likely, this is likely, very likely, or high, most likely this patient will have a DVT. So we are going to offer for this patient a Doppler ultrasound within 4 hours. Okay, if it came negative, we are going to do the D-dimer. Okay, if the patient cannot do the ultrasound within 4 hours, which is I think unless you are working in a peripheral hospital or just a small polyclinic at the periphery, I think it usually readily available the Doppler ultrasound. But if there was no Doppler ultrasound available and the patient cannot do it within 4 hours, we are going to do a D-dimer, and we are going to start the anticoagulation regardless of this patient has a DVT or not. And we are going to prepare, we are going to check if the ultrasound can be done within 24 hours. Anyway, the algorithm, the stepwise approach for managing or approaching the patient with the DVT, it's available in the NICE website. I can post for you the link to the guideline in the WhatsApp group. Okay, remember just what I want you to remember. If we have to request for this patient an ultrasound, Doppler ultrasound within 4 hours, if it came negative, we are going to do a D-dimer. Okay, this is what I want you to remember from the whole guideline. It contains a lot of information. It was recently updated in 2020. Those are the important points in the update. But if you interested to know the details, and I highly recommend from every one of you to go and check the new guideline, because DVT, it's a very common topic. It can appear at the exam at any center, and it's even going to help you in your usual practice. Okay. Okay. One of the new change to the guideline in the guideline that previously we used to start for this patient, we used to start low molecular weight heparin, and then we are going to start the warfarin, overlap with warfarin, and we are going to wait till the INR reach 2 or for at least 5 days. Then the patient, we are going to stop. Then we are going to stop then we are going to stop the heparin, and the patient is going to continue the warfarin. Right now, with the development of the new oral anticoagulant, they are now preferred to be used at the first line, even before the heparin, even before the warfarin. You have to give the patient ebexiban or rivaroxaban as the first line of management. Okay, so if the patient has a DVT, if the patient clinical history suggests, or the clinical examination suggested that he has a DVT, I'm going to do for him Doppler ultrasound. If the Doppler ultrasound came positive, I'm going to start for this patient either rivaroxaban or ebexiban. Okay, this is the new update to the guideline. Okay, if ebexiban or rivaroxaban, they were not available, then I'm going to go into the second option. The second line treatment also contain two of the new oral anticoagulant. In the second line of treatment, I'm going to give the patient low molecular weight heparin for 5 days. After 5 days, I'm going to give him dabigatran or edoxaban. The last line of management, which was previously the first line of management, which Dr. Komal mentioned it for me during the discussion of the case, which is to start the low molecular weight heparin with warfarin for at least 5 days, or until the INR reach 2 in 2 consecutive readings. Then after that, we are going to stop the heparin, and the patient going to continue the warfarin. Okay, this is a new update 2020 in the NICE guideline. I hope everyone can go back and check the new guideline, read it and revise it, because DVT is very common topic at the exam. Okay.
So if we are starting newer oral anticoagulants, then we don't need to admit. We can just send her.
Yeah, and this is one of the important questions that I ask you. Do we need to treat the patient as, sorry, I didn't ask you that, sorry. But you told me that I have to admit the patient. By the way, treatment of DVT, if the patient condition was stable, there is no risk factor for pulmonary embolism. It is not a recurrent DVT, and the patient condition, the patient think that he can, the patient was highly mobilized, and he has a suitable home condition. He has someone of his friend or family can take care of him at his home. He has a phone access, and he was able to return back at the hospital at any time. If all of those factors are present, we usually recommend the patient to be treated at home rather than the hospital. Okay, so if the patient condition was stable, the patient, there is no clinical symptoms or from the examination, something suggests that this patient has pulmonary embolism. The patient is highly mobilized. The patient he has a proper home condition, someone of his family or friend to take care of him. He has a phone access, and he can return back to the home at any time if it was required. If all those factors are present, we usually recommend or we usually let the patient go home, and we do not treat them at the hospital.
So even if we're giving
Can you
molecular weight
repeat management
heparin,
again?
then even if we're giving low molecular weight heparin, can we send home then? We cannot send home.
No. Of course. You can't. If you don't have the new oral anticoagulant, you can't. You have to treat the patient at least for 2 days or till the NR reach 2 for 2 consecutive readings. Okay. Previously it was
right.
for at least 5 days. Nowadays it's only for 2 days. Okay.
And for Behçet's, we'll have to give lifelong oral anticoagulation. What's the
Okay, the duration for anticoagulation, it depends on the risk factor. If this patient has a risk factor, recurrent DVT, there is provoke risk factor, like for example, provoke not lifelong condition. For example, it was just following delivery or following a fracture or following recent hospital admission. The patient can take the anticoagulant just for 3 months. If it was unprovoked, you have, and there was no clear risk factor, he have to take the anticoagulant for 6 months. If there is underlying cause for the recurrent DVT, and the patient has a risk factor, high risk, one of the lifelong risk factor for thrombophilia, the patient has to continue the anticoagulant for his whole life. Okay? Like for example, if the patient has Behçet, if the patient has one of the thrombophilia risk factor, protein C deficiency, protein S deficiency, antithrombin 3 deficiency, prothrombin mutation, one of those, if the patient has one of those conditions, he has to take the anticoagulant for his whole life. Okay?
Dr. Ala, can you repeat anticoagulant management for DVT?
Anticoagulant management. Okay, if you have to give the patient, if you confirm that this patient has, if this patient has confirmed DVT, or even if he has pulmonary embolism, you have to start with apixaban or rivaroxaban. Okay? This is the first line management. Okay, if both of them not available, I'm going to give the patient low molecular weight heparin for 5 days. Then I'm going to start another or a different new oral anticoagulant, dabigatran or edoxaban. Okay, this is the second line, the second option. The third option of treatment in the patient with the DVT, which was previously the first line of management or the preferred approach for treating the patient with DVT, it was to start the low molecular weight heparin, start the warfarin, measure the INR every day. When the INR reach 2, or if the patient stays for 5 days at the hospital, then we are going to stop the heparin and he is going to continue the warfarin. Okay?
Okay, and how about the doses of apixaban and rivaroxaban?
Well, I'm not quite sure about the doses, doctor, to be honest with you, but the usual and the standard dose, this is something is going to be determined by the treating doctor or by the specialist who is taking care of the patient.
Sorry, Dr. Ala.
Yeah.
Dr. Ala.
Yes, doctor.
For apixaban, 5 milligram BID.
Okay. Thank
5
you,
milligram BID. Another question, Dr. Ala,
I think,
about
sorry
the
for interruption.
anticoagulation in Behçet disease.
Yes, doctor.
I think, as I remember, it is to start immunosuppression first, and then anticoagulation later.
Okay, the treatment of Behçet disease usually depend on the presenting symptoms. There is no single line or single treatment for the patient with Behçet disease. Behçet disease is in reality, it's a syndrome. So the patient can present with a lot of symptoms, a lot of organ involved. So the treatment of the Behçet disease, if the patient present if the patient presents with oral ulcer and genital ulcer, we are going to give him topical agents such as topical lidocaine or topical corticosteroid. Okay? If the patient presents with erythema nodosum or present with arthritis, we are going to use colchicine. If the patient presents with uveitis and red eye, we are going to give him azathioprine or cyclosporin. Okay? And so on. The treatment usually depends on the presenting symptoms. If the patient presents with a DVT, usually like this patient, for example, the patient with Behçet disease, the current complaint is DVT. Usually those patients with the treatment of the DVT, we give them immunosuppressive agents such as corticosteroid, azathioprine, cyclophosphamide. Okay? You have to combine both the treatment of the DVT in addition to the immunosuppressive. Okay? If the patient with Behçet disease present with neurological manifestation, sometimes they can present with headache, ataxia, they can present with even cerebral venous thrombosis. You need to start for them high dose corticosteroid. I know the treatment of Behçet syndrome, it contains a lot of details. I just want from you to remember the main thing. Even I think at the exam, the examiner is not going to go deep with you in the treatment of Behçet syndrome. But anyway, if you want it, I have already mentioned it for you. Just to answer your question, doctor, with just a simple answer, yes, if the patient has a DVT, we have to start immunosuppressive medication in combination with the anticoagulant. Is that your question, doctor, or?
Yes. Thank you, doctor.
You are welcome.
Yes. Also, I remember the apixaban, 10 milligram for the first week or 10 days, then 5 milligram BID.
Okay.
According to the is it provoked or unprovoked?
Okay. Actually, in the NICE guideline, they did not define, or they did not specify the dose clearly. But I think you can use the BNF. You can use any website that, or even you can download the leaflet for the medicine if you want from the manufacturer website. It can contain for you. It can show you exactly what is the recommended dose for the patient with the DVT. Okay. The most important thing, I think, at the exam, they want from you to know if you are aware and updated with the recent guideline for managing the DVT or not. This is the most important thing. I don't think there will be a time to discuss with you the dose and those details. Okay, so don't be worried about those things. But if you are interested, you can go and check them.
Dr. Ala, what is the examination of Behçet disease?
Examination of Behçet disease, I have to start first with the pulse. Start the general examination. You have to go then into the eyes, looking for the presence of the red eye because the patient may have a uveitis. I have to examine the mouth, looking for the mouth sore. Then I have to go into the genital area, and this is very important thing, doctor. You didn't ask me that question. You didn't offer for me to examine the genital area. It's very important to detect the mouth sore. Other part of the examination depend on the presenting symptoms. For example, if he told you a skin rash, you have to look for his leg to detect the erythema nodosum. If he told you that I have an abdominal pain, this patient may have, sometimes they may have mesenteric ischemia. You have to examine the abdomen, look for the tenderness, okay, looking for the organomegaly. If the patient has cerebral venous thrombosis, I have to examine full neurological examination, the upper limb or the lower limb. So usually we are going to examine the patient according to the current complaint or current presentation. Because as I said before, Behçet syndrome, Behçet disease, it's not a disease, it's a syndrome. The patient can have arthritis, the patient can have erythema nodosum, he can have neurological manifestation, he can have ocular manifestation, he can have a DVT. So you can't examine all those part of the body. just within less than 1 minute or 1.5 minutes. For this patient, for example, because his presenting symptoms was a DVT, I have to examine the leg carefully and properly. Then I have to look for the other systemic manifestation of the Behçet disease. And I'm going to look for the thing that were positive from the history. I'm going to look for the mouth, and I'm going to look for at the genital area. No need to examine the CNS. I'm not going to examine the joint. I'm not going, if I have a time, I'm going to look at his chin. But if I don't have a time, I'm going to ignore it. Okay? And Behçet disease can also cause sacroiliitis, can cause back pain. So it's very difficult to examine all the part of the body that can be affected by Behçet syndrome. I think in one of our previous sessions, we discussed how we diagnose Behçet syndrome. If you want me to repeat it, I can repeat it again. Just quickly, usually there is a clinical criteria. The diagnosis of Behçet syndrome or Behçet disease, it's a clinical criteria. The patient should have a recurrent oral ulcer 3 times or more over the last year. Okay. In addition to that, 2 of the following 4 criteria should be fulfilled. So number 1, the patient should have recurrent oral ulcer 3 times or more per the last 12 months. In addition to that, the patient should have 2 from the next following criteria. Number 1, the patient should have an eye lesion, either anterior uveitis, posterior uveitis. The second thing is skin lesion, erythema nodosum mainly. The third thing is recurrent genital ulcer. The fourth thing is the positive P-therapy test. Okay? If the patient from those 4 criteria, he has a 2, in addition to the recurrent oral ulcer, I'm going to say this patient has Behçet syndrome. Okay? Okay.
Sorry, Dr. Ala, can you repeat that again?
Okay, the diagnosis of Behçet syndrome, the patient should have recurrent oral ulcer 3 times or more per the last 12-month period, in addition to 2 from the following criteria. Number 1, the eye lesion, like anterior uveitis, which is the commonest one. The second thing is the skin lesion, like erythema nodosum. There are other skin lesions, but we are not going to talk about them at our current level. The third thing is the recurrent genital ulcer. The fourth thing is positive P-therapy test. If he has 2 out of those 4, in addition to the recurrent oral ulcer, we are going to say this patient has Behçet syndrome. One important thing in the blood test, we can check for HALA-B 51, but it is not enough or specific to diagnose Behçet syndrome. Okay?
Thank you.
You are welcome.
What is the investigations of Behçet?
Investigation of Behçet? You are going to do just a general blood investigation like CBC, complete blood count. You are going to check the inflammatory marker like ESR and C-reactive protein. This patient, because he has a DVT, you are going to check the coagulation profile. You have to check the HALA-B 51. Then the other investigation depends on the presenting symptoms. If he has a joint pain, I have to do an X-ray. If he has cerebral venous thrombosis, I have to do MRV, and so on. Okay, but there is no specific test for Behçet syndrome. If I was thinking about antiphospholipid syndrome, I have to check for beta-2 glycoprotein. I have to check for anticardiolipin and lupus anticoagulant, and so on. Okay. The most important thing are the CBC, C-reactive protein, ESR, HALA-B 51, in addition to the P-therapy test. Those are the important tests that you have to request them at the initial level. Okay.
What is the value of C-reactive protein here?
Because it's a form of vasculitis, you can find that the C-reactive protein and ESR maybe they are elevated. They are most likely to be elevated. during
Yes,
the active phase of the disease. If the patient has an active phase of the disease, he was in the active phase of the disease, you are going to find that the C-reactive protein and the ESR are elevated. Okay.
okay.
Other investigation, as I already mentioned, it depends on the presenting symptoms. You may do a CSF analysis, you may do an MRV, and so on. Okay, so let's talk a little bit about the thrombophilia risk factor. What are the risk factors for thrombophilia and how can I apply them? I think I mentioned that before, but I'm going to repeat it just for the recording sake and for the colleague who never heard that from me. Number one, I have to ask the patient, I'm going to, the risk factor, I'm going to mention them according to their orders in the history. Like for example, when I'm taking the history in the patient, I'm going to ask him in the beginning history of the present illness and systemic review. Then after that, I'm going to the past medical history. Then after that, I'm going to the family history. Then after that, I'm going to the drug history. Then after that, I'm going to the female history. So the order of the question here is according to our order of the history or the different aspect of the history. Number one, we have to ask the patient about the mouth sore and sore in the private region. Why? Because we want to exclude the Behçet syndrome. It's very important at the PACES level. Very important case at the PACES level. Number two, we have to ask the patient about the morning discoloration of the urine. To exclude the paroxysmal nocturnal hemoglobinuria. It's one of the frequently appearing scenario in certain centers. So we have always to keep this question in our mind. The third question, I'm going to ask the patient about the frothy urine to exclude what? To exclude the nephrotic syndrome. Nephrotic syndrome, as we know, it can increase the it's one of the disease that can predispose the DVT or can cause coagulopathy. The frothy urine. The question number 4 is the chronic diarrhea. Chronic diarrhea, why? Because we want to exclude the inflammatory bowel disease like ulcerative colitis and Crohn's disease. Those conditions, they can also lead to increase the chance or increase the risk for developing the DVT. So those are the 4 questions in the in the history of the present illness and in the systemic review. Then I'm going to go into the past medical history. I'm going.
Please, معلش doctor, again this question again. Sorry.
Okay. From the beginning, I'm going to ask the patient about the mouth sore and sore in the private region to exclude the Behçet syndrome. The second question is morning discoloration of the urine to exclude the paroxysmal nocturnal hemoglobinuria. The third question I'm going to ask about, the third question is the frothy urine to exclude the, or bubbles in the urine to exclude the nephrotic syndrome. The fourth question is chronic diarrhea to exclude the inflammatory bowel disease. Okay? Then I'm going to proceed into the past medical history. I'm going to ask the patient about the history of clot. If the patient has recurrent history of clot, you have to think about the hereditary thrombophilia, like the protein C deficiency, the protein S deficiency, the antithrombin 3 deficiency, factor 5 lydin mutation, prothrombin mutation. Okay, you have to think about the hereditary thrombophilia. The other question is if the patient has history of cancer. Okay, if the patient has a history of cancer, how can I will ask the patient directly if he has a history of nasty growth, history of cancer. I can even ask the patient about the lumps and bumps, loss of weight, and loss of appetite to exclude the cancer. Remember that cancer is one of the important risk factors for DVT, and you have to never forget it at the exam. Okay, always remember the cancer as one of the important risk factors for the DVT. Then in the past medical history, again, I'm going to ask the patient about recent history of admission, recent history of surgery, or any disease made you bedridden or make you bedridden. This is also one of the important questions in the past medical history to detect if the patient has any risk factor for thrombophilia or for DVT or pulmonary embolism. Then I'm going to proceed into the recent history if he had any recent history of travel. Okay. Then after that, you have to ask the patient if he had a family history of clot. If there is a positive family history of clot, this is going with the diagnosis of hereditary thrombophilia. Okay. Then after that, I'm going into the female history. If the patient was a female, I'm going to ask her if she is currently pregnant or not, because pregnancy on its own can increase the risk for the DVT or pulmonary embolism. Then I'm going to ask the patient about history of recurrent miscarriage to exclude the antiphospholipid syndrome. Then I'm going to ask the patient if she is taking any oral contraceptive pills or if she is taking any hormone replacement therapy. Hormone, if she is taking hormone, especially estrogen, it can increase the risk for DVT or pulmonary embolism. So I'm going to repeat them from the beginning. If the patient has a mouth sore or sore in private region, if the patient has morning discoloration of the urine, if the patient has frothy urine, if the patient has a chronic diarrhea, if the patient has a history of the clot, if the patient has a history of the cancer, if the patient has a recent history of admission, surgery, or any disease made him bedridden, if there is any recent history of travel, if there is a family history of the clot, if the patient is currently pregnant, if the patient has a recent history of delivery, if the patient has a history of recurrent miscarriage, if the patient is taking any oral contraceptive pills, if the patient taking hormones, those are the thrombophilia risk factor. Okay? Okay, this when we ask those questions, usually in the exam, think about the thrombophilia, or you have to ask about the thrombophilia if your case was either DVT, or it was pulmonary embolism, or it was cerebral venous thrombosis. Okay, those are the three important thromboembolic disease that commonly appear at the PACES level. Okay, DVT, pulmonary embolism, and cerebral venous thrombosis. But there are other diseases which can be caused by the venous thrombosis, and they are include mesenteric ischemia, patient with abdominal pain, portal vein thrombosis, abdominal pain, Budd-Chiari syndrome, severe acute abdominal pain with jaundice, central retinal vein occlusion, sudden blindness, painless blindness, patient with splenic vein thrombosis. The patient may have portal hypertension and hematemesis, and sometimes the patient may have condition called Paget-Schroeder syndrome. This is a thrombosis in the upper limb. Those are many diseases. I think at the basis level we can't remember all of them. But I would like you to focus on the first three disease, which is DVT, patient with a leg swelling, pulmonary embolism, the patient presents with shortness of breath, chest pain, cough with hemoptysis, cerebral venous thrombosis, the patient will present with a headache, focal neurological deficit like weakness or numbness in one of his limbs, and he may present with a feature of encephalopathy like coma. He may present with diplopia. Those are the three important diseases that you have if your case, you suspect that your case or your final diagnosis will be one of those conditions. You have to ask the question that we have already mentioned previously. Okay. Okay. I'm talking to myself or what? Hello.
No, okay. It's
Yes,
very,
doctor. Yes,
very
doctor.
good case. Yes.
Okay.
Very well explained. Thank you.
Okay. One more thing, just
Thank
before
you,
we
Dr.
finish.
Ala.
Just one more thing before we finish our discussion. If the patient presents with a leg swelling, okay, leg swelling at the exam, What is the approach for the patient presenting with a leg swelling? If it was unilateral leg swelling, like in this patient, he had a leg swelling in his right leg, I have to think, number one, about DVT. DVT, the patient will have a recent history of leg swelling. It will be associated with pain, sometimes redness, hotness, and in addition to the swelling, the pain, redness, and hotness, in addition to reduce the mobility of the patient. The second thing is the trauma or muscle strain, tear, or twisting injury to the leg. This is the second differential. I have to ask the patient about the trauma. The third differential is Baker cyst or popliteal cyst, rupture Baker cyst. Usually the patient will have a swelling behind his knee that after the while this swelling moved from behind his knee into the calf. This is going with the Baker cyst. Baker cyst is very common in the patient with rheumatoid arthritis. The fourth differential is cellulitis. Cellulitis, you have to ask the patient about the fever. It is very similar to the DVT. The last differential is the lymphangitis. Lymphangitis, usually the patient will have either wound infection. For example, he had a wound. This wound, he will have an injury or skin abrasion. The bacteria is going to spread into one of the local lymph node. The lymph node maybe will get obstructed or inflamed. It will lead to the limb swelling. Okay, so those are the important differential if the patient has unilateral leg swelling. Number one, the DVT. Number two, the muscle strain. Number three is the Baker cyst or rupture Baker cyst, to be specific. Number four is the cellulitis, and number five is lymphangitis if the patient has unilateral leg swelling.
In the case of DVT, do we offer physiotherapist and occupational therapist help?
Occupational therapist, it can be, but physiotherapy, no need for physiotherapy in the patient with a DVT because the patient is going
it can cause embolism.
No, not. By the way, usually the patient with the DVT, we recommend from the patient to be highly mobilized. It is this is the recommended or the preferred advice that you have to give it to the patient. Bed rest and immobilization is not recommended for the patient with the DVT. Usually, we advise the patient who have a DVT to be highly mobilized. Okay, and because the course of the disease is very short, we don't need physiotherapy. The patient will not be immobilized for a long period, so he will not develop any weakness. He will not develop any contraction. So there is no need. No need to refer him to the physiotherapy. Okay, so this is the list of differential for the patient has or the patient have unilateral leg swelling. If the patient has bilateral leg swelling, this is most probably could be one of two things, either bilateral DVT or an edema. Okay, bilateral DVT, it is very common in the patient with the cancer. Okay, and it appeared before in the exam in Al-Ma'adi Center in Egypt. A patient with a cancer developed bilateral leg swelling and he had a bilateral DVT. One of the very difficult scenario, but we can learn from the previous experiences. So please remember that the differential for bilateral leg swelling, it is one of two things. Either it is edema or it could be a DVT, bilateral DVT. Okay? The causes of edema, it could be a disease within the heart. The patient may have a heart failure, okay? Or a disease within the lung. The patient may have a pulmonary hypertension, okay? Or a disease within the liver. The patient may have a liver cirrhosis. Or a disease within the kidney. The patient may have a chronic kidney disease, or he may have a nephrotic syndrome. It could be a disease within the gut or the small bowel. The patient may have a protein losing enteropathy. The differential for protein losing enteropathy is wide range list of differential that contain a lot of disease that can cause protein losing enteropathy. Just in the exam, remember the malabsorption like celiac disease, remember the inflammatory bowel disease, and it could be a cancer within the pelvis. It could be a disease within the thyroid, like Graves' disease can cause peritoneal mesoedema. Or the last thing, it could be drugs. Remember that the most important drugs, the most common drug that can cause lower limb edema is the calcium channel blocker like the amlodipine and nifedipine. Okay, there are other drugs like vasodilator and anti-diabetic medication like thiazolidinedione, bioglitazone specifically. It can cause bilateral leg edema, bilateral lower limb edema. So I'm going to repeat the differential again for the bilateral leg swelling. It could be two things, either DVT, bilateral DVT, especially in the patient with a cancer, or it could be an edema. If it is edema, it could be a disease within the thyroid gland, like Graves' disease. Graves' disease can cause peritoneal mesoedema. It could be a disease within the heart. The patient has a heart failure. It could be a disease within the lung. The patient has a pulmonary hypertension. It could be a disease within the liver. The patient has a liver cirrhosis. It could be a disease within the gastrointestinal tract. The patient has protein losing enteropathy due to, for example, malabsorption and inflammatory bowel disease. It could be a disease within the kidney. The patient may have chronic kidney disease, or he may have nephrotic syndrome. It could be a pelvic cancer, pelvic neoplasm, which is unlikely to appear at the PACES. And the last thing, it could be a drug, and remember, please, the calcium channel blocker. Okay?
How to differentiate between
Yes,
DVT and
doctor.
superficial thrombophlebitis?
Superficial thrombophlebitis, it usually or eventually it can lead to the DVT, and the exam, it's very difficult to differentiate them. Okay, doctor?
Okay, and the same management also.
Yeah, most probably superficial phlebitis at the end is going to cause the DVT. And it's one of the chronic venous insufficiency. It's in addition to the superficial thrombophlebitis, one of the common cause of the bilateral leg swelling. But most of the patient ultimately or eventually they will develop DVT. So basis wise, think about the DVT. Okay, without going into too much detail or further detail. Okay. Okay. If we want to talk about those diseases just quickly, heart failure, remember in the exam, the patient will have shortness of breath, which is the common presenting feature. Pulmonary hypertension, usually there are many causes of pulmonary hypertension. It could be a chronic lung disease. It could be autoimmune disease, especially systemic sclerosis, one of the important cause of the pulmonary hypertension basis-wise. There are many causes of portal hypertension, of pulmonary arterial hypertension, like HIV, schistosomiasis, congenital heart disease, valvular heart disease. Remember just the chronic lung disease, remember the valvular heart disease, and remember systemic sclerosis. Those are three important causes of pulmonary hypertension, which can lead to the leg edema. Graves' disease, the patient will have tremor, he will have excessive sweating, he will have palpitation, he will have the eye symptoms. Liver disease or liver cirrhosis, ask the patient about the jaundice, yellowish discoloration of the eye white, ask the patient about the pain in his tummy, and ask the patient about the risk for hepatitis, like the sharing the needles and like the tattooing, like the blood transfusion. Kidney disease, the patient may have a chronic kidney disease, either chronic kidney disease or chronic renal failure, patient with diabetes, patient with hypertension, patient with any medication that can cause chronic kidney disease. Nephrotic syndrome, usually at the exam, it can appear with many conditions, but remember mainly the drugs. There are five causes of nephrotic syndrome. Whether it is primary glomerular disease or not, I'm not going to go into the details. Just remember the rheumatoid arthritis, ankylosing spondylitis, any disease that can cause, and diabetes, all of them, they can lead to amyloidosis, and amyloidosis can lead to nephrotic syndrome. Last thing, ask about the calcium channel blocker, ask about the bioglitazone, ask about the vasodilator like hydralazine in the drug history to exclude that the cause of the lower limb edema, it could be one of those medication. Okay, I'm sorry if the approach for the bilateral leg swelling is a little bit broad, but better to mention everything, so we will be able to cover anything that appear at the exam, even if it was not a commonly or frequently appearing case. Okay?
Okay, doctor.
Okay. Any question? Any question, يا شباب؟ Any question? Anyone has any question regarding the DVT, thrombophilia risk factor, unilateral leg swelling, bilateral leg swelling, Behçet syndrome?
Doctor, you explained so nicely. No question remains.
Thank you, doctor. Thank you. Okay, if there is no question, we are going to stop here. This session was recorded. I'm going to share the recording in the YouTube, in the SoundCloud, and I hope you find this session was helpful. Thank you everyone for listening and for attending and for bearing with me all this 1 hour or 1.5 hours. Thank you everyone, and see you inshallah.
Thank you very much.
Inshallah in the future.
Thank you, doctor.
Inshallah. Thank you. Welcome. Welcome, doctor.